Actually, there was a small mistake. I told in the last moment that IU will be kept in service, right? No, actually it must be kept in uterine cavity, no? So actually I was supposed to say that through the cervix, the intrauterine device or either copper or whatever it might be, will pass through the external os and then internal os and then into the uterine cavity. But there is a chance of piercing the posterior wall of the vagina. Okay, I was about to say this, but a mix-up has happened. So somebody tell me the boundaries of the the pouch of Douglas. Recto-uterine folds, and then one more. Recto-vaginal. Actually, recto-cervical I have changed it later, but actually recto-vaginal fold. Recto-cervical fold as a whole is termed as the pouch of Douglas. Recto-cervical fold, the same peritoneum, is termed as the pouch of Douglas actually. Okay. But the three folds are, one is the recto-uterine folds on either sides, and the below one is the recto-vaginal fold. Okay, these are basic ones. What are the true ligaments? What are the true ligaments which are passing beneath them? No. True ligaments which are passing beneath the two sacro-uterine ligaments. Okay. Could somebody please tell me what are the true ligaments and false ligaments of the uterus? Anybody? True ligaments and false ligaments of the uterus? Anybody? From the last people? What are the true ligaments and with what it is made up of? True ligaments? True ligaments are made from endopelvic fascia. Contains the last guys. Somebody tell me the true ligaments and false ligaments of the uterus? Somebody? Anybody? No, the last guys? Nobody here? No? Seriously? What people are doing here actually? What people are studying? Everybody? What's it? Yeah, it's okay. What is this topic? So how to keep the stomach in anatomical position? Anybody? How to keep the stomach in anatomical position? Which surfaces are coming off? Anterior surface and posterior surface. Lesser curvature will be facing towards right side and greater curvature will be facing towards left side. So which area of the stomach is more prone for gastric ulcer and why? Lesser curvature. Submucous plexus will be absent. So what will happen?
Anastomosis.
It is entering into the submucosa, the veins will be returning back. So the blood supply will be less.
And also gastric canal.
Gastric canal. Actually, what is happening with the gastric canal?
So when liquid or urine fluid directly passes
Exactly. So whenever the liquid, if you take, that will pass through the gastric canal. For example, the patient has been taking the alcohol for so long. So obviously, the alcohol, what is that? What it does normally? Irritate. Okay, so obviously the lesser currents will be irritated. That leads to inflammation. That leads to perforation. Okay, that's nothing but the gastric ulcer or water perforation, water. Okay. In the duodenum, where is the common site for the peptic ulcer? First part of the duodenum. Why? Acidic chyme will be entering immediately. So obviously the first part and the two proximal half of the duodenum is more prone for ulcer. Which duodenal ulcer is more dangerous? Anterior or posterior?
posterior.
And why?
Because it will load the artery that is.
Which artery? Gastroduodenal artery to perforate it. So obviously what will happen? Okay. So what is it? Internal hemorrhage will happen. So obviously the patient will die. Very good. Okay. So how to differentiate the bleeding from the stomach and from bleeding from the small intestine or large intestine? Dark colored. What is stomach ulcer? Dark colored. So the last guys, why the stomach ulcer bleeds, and then the color of the blood will change to which color? The last 4 guys, 4 or 5 guys. How to differentiate the gastric ulcer and peptic ulcer? The last guys on either sides. You are staying in hostel, no? You staying in hostel, no? Hostel, you will shout, no? You will shout in the hostel. So in the same manner, you have to shout it. So then I can understand. Okay, come on, say it.
shout করি না তো একটু
What is it? What is it?
এত দম কোথায়
What is it? HCl? HCl, that is the breakdown of the RBC. So that leads to an odd color. What is the color? Dark brown in color or blackish in color. Okay. Okay, fine. Obstruction of the duodenum. Because of these structures, there will be obstruction of the duodenum. Because of these structures, there will be obstruction of the duodenum. On the second part especially, and third part also. Annular pancreas. And then for the third part, chantry, superior basal ganglia with respect to the exactly, and aorta. Why it happens?
Fat
Fat will be reduced. Fat will be reduced. Okay. And then, so duodenojejunal flexion will be held in position by means of a ligament. What's the ligament? Ligament of Reis. It will be arising from right crest of the diaphragm in the duodenojejunal flexion. Duodenojejunal flexion. Okay, today only colon, so I'm just revising the things important.
Okay. Thank you, sir.
Okay.
But how to make the answers in referred pain cases?
Referred pain cases based on the sympathetic nervous system supply.
How to write the answers? They said
So you know how the referred pain occurs seasonal or not? You know? No. It's okay. Okay. Let me take an example. For example, first of all, mainly appendix will be given and the radiating pain will be given. Okay. First of all, the appendix, where will be arising? Where will be arising? Below the iocecal junction, about 2 centimeters below the iocecal junction, there will be also the appendix, base of the appendix. Okay. So if there is an appendicitis. How the appendicitis occurs, we have already discussed. What is it? How the appendicitis occurs normally? What is it? Non-common phenomenon. You got oxytic cells. Oxytic cells you are saying about venous private, not appendix. Appendix, how the inflammation occurs. Bacterial, how the bacteria will occur? Fecal matter. So fecal matter will be getting trapped over here and becomes what is the main function of the large intestine? What is the main function of the large intestine? Anyway, absorbs water and of course few electrolytes will be absorbed over here. Okay, and of course synthesis of the vitamin B and K. Right. So main function of the large intestine is the absorption of water and electrolytes. So whenever the fecal matter enters in a semi-solid form over here, so what will happen later? There is a term called, what is the term? Exactly, what is the fecal means? Whenever the stool over here, that means the fecal matter dries up over here, it will become hardened and becomes stone-like. So that is what the feco-lit. Feco means fecal matter, lit means stone. So it will become stony hard. So whenever there is an obstruction to this lumen, because of the stony fecal matter is an irritant. Okay. So this irritation will be leading to the appendicitis over here, and this appendicitis leading to the obstruction of the appendicular artery which is supplying the tip over here. Okay. So this inflammation leads to swelling of the appendix over here, nothing but the appendicitis over here. This swelling will be compressing this appendicular artery. That leads to the obstruction to the blood flow to the tip of the appendix. That leads to perforation of the appendix. That leads to leakage of the things which are releasing from here into the peritoneal cavity. Okay. In initially there is an appendix over here. There is a localized peritonitis. It is covered by the cecum and all the small intestines will be covered by the greater omentum over here. Is it not? So the greater omentum contains macrophages. So that will be fighting against the pathogens over here. So obviously this will be localized over here. Okay. What is it? Localized peritonitis over here. Okay. So if the patient is not being treated over here, this will become generalized peritonitis. Okay. So initially there is a localized peritonitis whenever the patient presents with the flexion of the hip and medial rotation of the hip, which muscle might be getting irritated because of the pelvic appendix over here. Pelvic no. That is obturator internus. Here will be the obturator internus over here. That will be irritated. So obviously, to prevent the spasm of the obturator internus, he will be relaxing the obturator internus. Could you understand? So to relax the obturator internus, he should flex the hip joint and medially rotate the hip joint. But in case of retrocecal appendix, it will irritate the psoas major. So if you extend the hip joint, if the patient feels the pain, so that indicates the retrocecal appendicitis over here. Okay. So initially, this is the appendix which is supplied by sympathetic nerve. What might be the sympathetic nerve? Supplying is T10 exactly. Okay. So yeah. So first of all, this is the spinal cord. This is at the level of the L1 vertebra, lower border of L1 vertebra. Okay. So this is supplied by what is it? T10, for example. This is the T10 segment of the spinal cord. Okay. So this sympathetic system is supplying the appendix over here. Okay. So the nerve, sympathetic nerve, all the way from the T10 segment of the spinal cord is supplying the appendix over here. So the same will be carrying the nerve fibers. What is it? Sensation of pain from the appendix towards the spinal cord over here. At the same time, here there is an umbilicus over here. In front, there is an umbilicus over here. So that will be having the dermatome, which is nothing but a T10 over here. Get it out? T10 dermatome will be supplying the umbilicus over here. Okay. So this T10 also will be what will happen? The same. There is a communication between the viscera and that is a sympathetic nervous system along with the somatic nervous system. Sympathetic nervous system belongs to autonomous nervous system, but this is the somatic nervous system over here. It supplies the skin and different things over here. We will be discussing that later. First of all, the skin is supplied by the somatic nerve, which belongs to the T10 over here. Get it out? And the same sympathetic nerve arising from here will be supplying the appendix over here. So because there is a communication between the sympathetic nervous system and the somatic nervous system, but there is a communication, so this pain, whatever is going over here, will also be referred over here to the umbilicus over here. Getting it out? So sympathetic nervous system is supplying the appendix over here. Why sympathetic nervous system will be supplied over here? It will be relaxing the muscles of the appendix. And there is no sphincter over here. So it will be relaxing the muscles of the appendix over here. So at the same time, there is an appendicitis. The pain will be traveled through the same sympathetic nerve towards the spinal cord over here. Okay. But the nerve, somatic nerve, which is arising from here, spinal cord, from the same segment over here, will be supplying the umbilical region over here. But whenever there is a communication between these two over here, the pain, whatever is arising over here, it will be carried towards the spinal cord and the sensation will be felt in the brain. Okay, that's a different thing. But the same pain which is carried over here will also be radiated over here towards the umbilical region through the somatic nervous system over here. Because of this communication between the sympathetic nervous system and somatic nervous system over here. Okay, could you understand or not? How this somatic nerve communication occurs over here? For example, T10 is a thoracic nerve, is it not? Thoracic group of nerve from T1 to T12, right? So normally a spinal nerve emerges over here. That will be supplying different muscles and everything over here, but it is giving the cutaneous nerve, is it not? The lateral cutaneous nerve, anterior cutaneous nerve are coming over here. These will be acting as a somatic nervous system. Getting it or not? Getting it or not? Right? So in the same manner, there is a communication between the somatic nerve and sympathetic nerve over here. So the pain, whatever is getting over here, will be radiated towards the skin over here, skin around the umbilicus. So this is the referred pain. Could you understand or not? Could you understand or not? Right? Right. This is the mechanism of the referred pain over here. So anything else? Right? So the last guys, people are not answering. So what will you do then? The examination and later on also? Sorry, what is it? What is it? What is it? No, what I'm asking, why I'm asking is, so what you people are going to do, that's what I'm asking. So the last people, have you passed in the last trimester?
Last day, sir. Sorry, sir. My.
Semester means every 6 months. Trimester means every 3 months.
I thought this was the main.
স্যার ঠিকই বলছে ট্রাইমেস্টার
So who are passed in the last trimester? Lift your hands. Lift your hands. I want to see this.
পাস হয়েছে ও হ্যাঁ হয়েছে
Passed, huh? Everyone passed, huh? Oh, that's nice. So what about this trimester then?
No hands will be very.
Upcoming trimester?
Sorry.
No, so, we'll see that.
It's too much.
So what the true fascia and false fascia of the kidneys? The true fascia and false fascia of the kidneys? True fascia is particular. You have to find out and tell me. Find out and tell me. It is written in diffuse histology. Diffuse histology.
বইয়ের নাম বলে যাচ্ছে কোলন করা যদি শুক্রবারে আসি তাহলে ভিডিও করবে আর হ্যাঁ যদি শুক্রবারে আসি রেকর্ড করতে পারবি যদি কেউ রেকর্ড না করে তোর ফোনে রেকর্ড করবে ঠিক আছে সব ডিপস করে রেকর্ড যাওয়ার সময় নিয়ে যাবো স্যারকে জিজ্ঞাসা করতে এই যে বইটা বাবারে অনেক দাম হয়ে যাবে কিনে হয়ে যাবে স্যার এই বইটা পড়তে হতো না দেখ আর ডাউনলোড করে নিবি আর ফোনে পড়বো ডাউনলোড করে ফোনে পড়া যায় না দেখ এই এটা বইয়ের নাম কি বই আমার নামটা বললি ডিভিডি হিস্টোলজি আইবিসি পড়ে উঠতে পারবো আইবিসি কিনেছিস আইবিসি হিস্টোলজি ওই ডিফিউডি কোথায় ডিফিউডি এটাই মনে হয় ডিফিউডে ভুলটাই হাত দেওয়া হয়ে গেছে ওইটা সরি অন্যটা ঠোঁটে হাত দেওয়া হয়ে গেছে।
So let us see the colons today. Okay. So let us finish it off first. It's a small topic. Okay. We have already discussed the cecum and appendix. Isn't that right? Right? Cecum and appendix. Yeah. Okay. So just below the transtubercular plane is a cecum over here. So above the transtubercular plane starts the which colon? Ascending colon. That's what's the length of the ascending colon and transverse colon, descending colon are important over here. So what are the measurements over here? The ascending colon will be 15 centimeters, transverse colon will be 50 centimeters, and descending colon will be 25 centimeters, and sigmoid colon will be 40 centimeters. These measurements you are supposed to know in case of colon. Okay, other areas if you don't know it's okay fine, but the colon centimeters you are supposed to know. Okay, and the diameter of the lumen of these ascending and transverse and descending colons gradually reduces. If it is 4 centimeters over here, where it comes over here, it will reduce to 3.5 centimeters like that. Getting it out, right? So these are the measurements of the colon, entire colon. What are the 3 cardinal features of the large intestine over here? What are the 3 cardinal features of the large intestine? Presence of the circulations. Circulations are produced because of. Circulations will be produced because of. Circulations will be produced because of what, right? These circulations, nothing but these dilatations will be produced because of the presence of these longitudinal muscles in the form of what is it? Tinea coli. Tinea coli are made up of convergence of the longitudinal muscle fibers. Okay. So the convergence of the longitudinal muscle fibers in the form of 3 bands over here. What are the 3 bands of the tinea coli over here? What is the tinea, libera, and then followed by tinea okay. Tinea mesocolica, and then one is tinea aumentalis. So by this you can understand to this region for the transverse mesocolon there will be attachment of the mesocolon over here, and for the aumentalis area this will be attached giving rise to attachment of the greater omentum over here, transverse colon. We will discuss that later. So there are 3 tinea over here, which are the longitudinal muscle fibers over here, which are arranged in front and 2 on lateral. 1 on in front, anterior aspect, 2 on posterior medial and posterior lateral aspects. What is the posterior medial aspect? Longitudinal muscle is termed as all the tinea will be starting from the base of the appendix over here. Okay, appendix doesn't have any. What's it? Tinea coli. Okay, all the 3 tinea coli, the tinea, libera, mesocolica, and aumentalis will be arising from the base of the appendix and goes upwards, and of course till the sigmoid colon they will go. Okay, rectum will be having a different sort of arrangement. We'll discuss that later. Okay, first of all the front one, the anterior surface of the ascending and descending columns, and even the sigmoid column also will be having tinea libera over here. What is the tinea libera on the anterior aspect? On the posterior medial aspect there will be tinea mesocolica, posterior medial aspect. Okay, on the posterior lateral aspect there will be tinea aumentalis. Okay, so this is constant for the descending colon also. Posterior medial aspect here will be, there will be tinea mesocolica over here, and on the posterior lateral aspect there will be tinea aumentalis over here. Getting it over? So this is the medial aspect of the descending colon over here. There will be tinea mesocolica towards the medial aspect, and posterior lateral aspect there will be tinea aumentalis over here, but libera will be in the middle. But in case of transverse colon, it will change. What will happen over here? What will happen over here? So the transverse colon will be rotated backwards because it is hanging over here all the way from the mesocolon, transverse mesocolon. It will be rotated backwards in this manner. So the tinea will be changing in their positions over here. So how it has been changed over here? Here the tinea libera will be on the. Here the tinea libera will be on the. So easy to understand over here. For example, so these three are the three tinea. For example, these three are the three tinea. What is the tinea libera, mesocolica, and omentalis with the ascending colon. But whenever it is reaching the transverse colon, it will rotate backwards. So, for example, this is the tinea libera. It will be coming on the inferior aspect. So now this ring finger is the tinea omentalis. That will be coming over upwards over here. Okay, towards the anterior aspect and upwards over here. And tinea mesocolica will be going backwards. Why it is so? Omentum will be attached in front and the mesocolon will be attached behind and libera will be coming below. Could you understand or not? Right? Tinea libera initially on the anterior aspect, now it has become inferior aspect. Get it? So now here this is the tinea omentalis, it is facing on the anterior superior aspect over here. Get it? And the what is it? Tinea mesocolica will be facing now postero superior aspect over here. Get it? Right? So posterior there will be tinea mesocolica now. On the anterior aspect there will be tinea omentalis because omentum will be attached over here. Is it not? From front to back the omentum will go. For example, this is the stomach over here and this is the transverse colon sagittal section. So for example, this is the greater omentum over here. The anterior 1 and 2 layers over here. That will become 3 and 4 layers over here. Is it not? So these are the 1 and 2 layers of the greater omentum. These are the 3 and 4 layers of the greater omentum. So this is the greater omentum. So on the anterior aspect there must be tinea omentalis over here. What are the posterior aspect? There will be tinea mesocolica. So tinea libera will be becoming inferior over here. Getting it? So the anterior aspect there will be tinea omentalis, behind this is the tinea mesocolica, and now below will be the tinea libera over here. In that manner, the positions will be changed over here. So now the lower aspect will be tinea libera over here. Towards the anterior superior aspect there will be tinea omentalis. Behind will be tinea mesocolica based on the attachment of the mesocolon and omentum over here. Greater omentum over here. Okay. And the same positions will be carried with respect of the descending colon and sigmoid colon also. Getting it? So here tinea mesocolica over, tinea omentalis over here, tinea mesocolica over here, and tinea libera over here in the center. So posteromedially to tinea mesocolica, posterolaterally there will be tinea omentalis over here. This arrangement you are supposed to know. Okay. But whenever it is reaching the sigmoid colon, distal 5 centimeters of the sigmoid colon, these three longitudinal bands will be joining together and form two bands over here. One is the anterior band and one is the posterior band. Anterior band is formed by tinea libera and tinea omentalis over here. Anterior band, for example, this is sigmoid colon. One anterior band will be there in the distal 5 centimeters that will be extending till the rectum over here. Okay. So at the rectum, this will stop. Anal canal will not have. Okay. On the posterior aspect, the tinea omentalis and tinea libera. Anteriorly, the tinea libera and tinea omentalis will be continuing as an anterior band over here, and the rest of the tinea mesocolica will form the posterior band over here. Could you understand? Tinea libera plus tinea omentalis will be forming anterior band over here, but the tinea mesocolica will be forming the posterior band over here. With respect to the distal 5 centimeters of the sigmoid colon and the rectum also. This you are supposed to remember. Okay. Tinea colon will be extending all the way from base of the appendix till the rectum over here. But 3 tinea colon will be present in the cecum, ascending, transverse and descending and sigmoid colons. But the distal 5 centimeters sigmoid colon and the rectum will be having only 2 tinea colon. What are those? One is the anterior, one is the posterior. Understood or not, right? So let us see the relations over here. First of all, what is the extent of these things? Ascending colon will be extending in between transtubercular plane or the distal end of the cecum over here till the, what is flexion? Right colon flexion. Right colon flexion. Right colon flexion is what? Is hepatic flexion or right colon flexion? What does flexion means actually? The bend is termed as a flexion. Do you know jejunal flexion, right colic flexion, left colic flexion? These are the bends of the colon over here. Can you know? So this is the right colic flexion or hepatic flexion. From right colic flexion to the left colic flexion, this colon is termed as transverse colon. So transverse colon contains both the flexures along with the colon proper. Okay, remember this proper. Ascending colon means from the distal end of the cecum in the flexion, right colic flexion over here. And transverse colon includes from right colic flexion, and this part of the colon is termed as the colon proper. Okay, try to remember this. Transverse colon includes right colic flexion, left colic flexion, and colon proper. That means in between the two flexures, this colon is termed as the colon proper over here. Okay, and then followed by descending colon will be extending in between left colic flexion till the sigmoid, beginning of the sigmoid colon over here. Okay, so we'll discuss the sigmoid colon later on. First of all, ascending colon will be present in which area of the 9 quadrants of the abdomen? Lumbar region. Okay, right lumbar region, not left lumbar region, right lumbar region. Okay, ascending colon will be present in the right lumbar region. Why right lumbar region over here? Why not right hypochondriac region? Liver will be present. Liver will be entirely occupying the right hypochondriac region. So colon can't reach the right hypochondriac region because of the presence of the liver. Okay. So ascending colon is shorter and will be situated within the right lumbar region over here. So if the patient complains of pain towards the right lumbar region, the first thought will be the infection of the ascending colon over here. Get it up? So what might be the relations of the ascending colon over here? What might be the relations of the ascending colon? Infront will be covered by peritoneum, so because that's why it is a retroperitoneal structure, and forming gutter over here, that is nothing but parabolic gutter. That will be continuous with the pouch above over here. What is that pouch? Renal pouch of Morrison. The hepatorenal pouch of Morrison will be communicating with the lesser sac behind the stomach through epiploic foramen. Okay, what are the boundaries of the epiploic foramen? Anybody? No? Anteriorly? Right free margin of the lesser omentum, and then behind? Inferior vena cava. Okay, through that space, the hepatorenal pouch will be communicating with the lesser sac. Above? Below? First part of it on the lower aspect of cloud boundary. Okay, so fine. So ascending colon is covered by the peritoneum over here and forms the parabolic gutter. Behind will be related to whatever the posterior abdominal wall structures over here. Those will be the relations. Behind this will be. There are two muscles over here. What are the two muscles? So absolutely towards the lateral aspect will be quadratus lumborum. So quadratus lumborum is covered by which fascia? Which layer? Anterior thoracolumbar fascia. In front of the quadratus lumborum, few nerves will be passing downwards. What are those? From above downwards? Iliohypogastric, ilioinguinal, genitofemoral nerve. Genitofemoral nerve is from psoas major. And one more is the lateral femoral cutaneous nerve of thigh. And one more above, just below the 12th rib will be subposterior. So all these nerves will be in relation to the posterior aspect of the colon over here. What might be the vessels which are in relation over here? You know very well. So here will be the renal arteries over here. So below will be lumbar artery, fourth lumbar artery, you can say that. And what are the other arteries? Gonadal arteries, absolutely. Below the renal arteries will be the gonadal arteries which will be going over here. Is it not? So those are the posterior relations of the ascending colon over here. Got it down, everybody? Right? And then above the ascending colon, this is the right colic flexion or hepatic flexion. What might be the relations? In front and behind. In front and above will be liver. Okay. Which lobe of the liver? Right lobe of the liver. Whether it will be covered by the peritoneum or not? No? Okay. Why it is covered by the peritoneum? ascending colon, descending colon, both are covered by the peritoneum on the post-abdominal wall. While this part, flexion is covered by the peritoneum. Mesocolon will be restricted with the transverse colon. Got it?
Like greater omentum Krishna.
See, the anterior aspect, it is related to the liver, right lobe of the liver. Right lobe of the liver is covered by the peritoneum or not? Apart from the bare area. You think that this colic flexion will be reaching the bare area? No, below the bare area. So obviously, it is indirectly covered by the peritoneum covering the liver over here. Do you understand? So in that manner, it is covered by the peritoneum over here. Got it? So behind it will be related to? Behind it is related to? Kidney, lower pole of the right kidney over here. Okay. So this is a right colic flexion over here. Okay. Right colic flexion will be passing towards the left side and will be becoming the transverse colon, which is about how many centimeters? 50 centimeters. Okay. So this transverse colon will be either U-shaped or V-shaped, lying below the stomach over here. Getting it or not? So it will be hanged all the way from the pancreas by means of a fold of peritoneum that is termed as transverse mesocolon. Okay, transverse mesocolon over here. Okay. So what might be the relations? Anteriorly and posteriorly. Anteriorly, the transverse colon will be related to
Greater.
what?
Greater omentum.
Greater omentum. Greater omentum. Greater omentum. Okay. Okay. By means of this tinea omentalis. Is not so greater omentum and any other? Infrared will be mainly. Whenever you lift up that a particular structure, then only you can see all the small intestines and the large intestine. What is that? What's that? See, stomach will be over here. The great omentum will be hanging in front of the transverse colon and the small intestines. Is it not? Like a curtain, the great omentum will be hanging in front of the transverse colon and the small intestines. Then it will turn back and will be holding the transverse colon over here. Is it not? So anteriorly it is related to the greater omentum over here. Okay. So behind it is related to all the way from here to here. If you see, this is the transverse colon. Is it not? Yeah. First of all, there is a lower pole of the kidney over here, then followed by the. So if the pancreas is over here, what might be the structure in between the pancreas and the kidney? What is it? Process over here. Duodenum, second part of the duodenum. So here will be the second part of the duodenum. In between the kidney and the pancreas, there will be duodenum. All these are the retroperitoneal structures. Okay, one beside the other over here. So if the duodenum, second part of the duodenum is over here, so that will be the posterior relation of the transverse colon over here. Then further leftwards, over here will be the uncinate process, and of course there will be root of mesentery over. Is it not? Root of the mesentery will be in relation with the posterior aspect of the transverse colon. And further leftwards will be jejunum. Coils of jejunum, Pakka. Jejunum and ileum are below the transverse colon. So the lower relations of the transverse colon is the jejunum. Is it not? The intestine, small intestine is situated within this gap over here. Further behind will be vessels. The larger vessels. What are those? Aorta and the inferior vena cava. Okay. And the further leftwards will be the lower pole of the left kidney, and above will be here with one structure which is related over here. That is nothing but the spleen. Which part of the spleen over here? Have you noted? There is the end. What is the end of the spleen over here? Lateral end of the spleen. Is it not? Lateral end of the spleen will be over here. That's why there is a renal impression over the spleen over here. Could you remember or not? So this is the medial end, this is the lateral end of the spleen over here. So towards the lateral end of the spleen will be the left colic flexure, which will be hanged by a fold of peritoneum all the way from diaphragm. What is that fold? Phrenico-colic ligament. Okay. So what is the clinical angle of the spleen over here? Clinical angle of the spleen. This is important. Clinical angle of the spleen. Clinical angle of the spleen. What are the two angles which are present towards the lateral end of the spleen over here?
Sir, 45 degree. Sir, 45 degree.
What is it? No, not that angle I'm asking. Exactly, anterior basal angle and posterior basal angle. Among these two, which is the clinical angle of the spleen and why? What right? Circuit. We'll discuss.
Fences puri.
See here, you can imagine that this is the superior border of the spleen over here, and this is the inferior border of the spleen over here, and this is the base, and this is the apex of the spleen. Okay, and this is the anterior basal angle, and this is the posterior basal angle. Okay, so how the splenic enlargement will occur? Vertically downwards or obliquely towards the right iliac fossa? Obliquely towards the right iliac fossa. Why? Because of the presence of the phrenicochoric ligament over here holding the colon over here, right? So this will not allow the downward movement over here. Then what is the clinical angle of the spleen over here? Clinical angle of the spleen, you just don't know. Anterior basal angle. So this is the anterior basal angle which is termed as the clinical angle of the spleen. So see properly over here, whenever the spleen is enlarging downwards over here. Okay, try to understand this properly, it's very much important. Whenever the spleen is enlarging downwards and obliquely in this manner, so the splenic enlargement will be further downwards enlarged over here, and this is the superior border now. Could you understand? Okay. So this superior border is the superior border over here, and this is the inferior border over here. And now this is the anterior basal angle, and this is the posterior basal angle. You can see this is the posterior basal angle over here, anterior basal angle over here. Okay. Whenever you palpate the abdomen over here, if you ask the patient by keeping the hand over the lumbar region or the umbilical region, if you ask the patient to inhale and expire, okay, inhalation and expiration over here. So this angle will be touching your hand, telling the spleen has enlarged over here. Could you understand? So whenever the splenic enlargement is present, all the way from what is this? Left hypochondriac region, then followed by the left lumbar region, then umbilical region, and right iliac fossa over here. Okay. For example, you are palpating over the umbilical region because you have found a mass over the left lumbar region over here. So you want to identify the size of the spleen over here. Okay, whether it is a spleen or any other structure. Okay. So for splenic enlargement examination, you have to palpate the abdomen all the way from the right iliac fossa obliquely towards the left hypochondriac region. Getting it out? To identify the splenic enlargement over here. Okay. Whenever you are palpating all the way from the right iliac fossa, and the patient will be constantly breathing, inhalation and expiration over here, inspiration and expiration over here. So the spleen will be moving with the respiration over here. So whenever you are palpating, if there is a splenic enlargement, the anterior basal angle will be touching your fingers over here, not the posterior basal angle. Posterior basal angle will be hidden inside. Okay. But the anterior basal angle will be touching the hand over here. That's why clinically this is important to identify the splenic enlargement over here. So the end which is touching the hand is nothing but the anterior basal angle. That's why it is termed as the clinical angle of the spleen. Clinical. You're trying to identify something clinically with respect to the spleen. So the angle which touches your fingers is nothing but the anterior basal angle over here. Getting it right? That's why anterior basal angle is termed as the clinical angle of the spleen, not the posterior basal angle. Remember this properly. It's very much important. Got it or not? Understood or not, everybody? Right? So these are the relations of the left colic flexure over here. Okay, and then followed by the descending colon. What were the relations? In front will be covered by the peritoneum again. Behind it is related to. Okay. So what? Okay. First of all, what are the areas in which the transverse colon will be situated? First of all, towards the right lumbar region. Then extends downwards into either umbilical region or hypogastric region, and will be reaching back into left hypochondriac region. There is no liver over here, so it can reach in the spleen over here. Spleen is situated in the left hypochondriac region over here. So all the way from the right lumbar region till the left hypochondriac region is the extent of the transverse colon, and in the middle it will be extending to the umbilicus or umbilical region or the hypogastric region over here. Getting it out? Because it will be hanging by means of the transverse mesocolon over here. Getting it out? So because of this hanging, it will be reaching the either umbilical region or the hypogastric region over here. Okay. So descending colon will be extending from left hypochondriac region to left iliac fossa. Okay. So left iliac fossa, nothing but indirectly you can say that there will be left lateral pelvic wall over here. So into the pelvis it will go. Getting it out? Okay. So the rectum will be formed at the level of S3 level. So sacrum. So you can understand this is from here is the sacrum, from this part is the sacrum. Above that this will be the lateral pelvic wall. So the sigmoid colon is situated within the lateral pelvic wall. So the descending colon will be reaching till the left pelvic brim, you can say that. Getting it out? What is that? Here is the transtubercular plane over here. Here is the left pelvic brim over here. What is the pelvic brim? Pelvic inlet. What are the boundaries of the pelvic inlet, right? Anybody? All the way from posterior to anterior direction? All the way from posterior to anterior direction?
Sacral promontory.
Okay. Even before that. Sacral promontory, then followed by anterior border of the ilium of the sacrum, and then followed by medial terminus, and then followed by pubic bone. Okay. So this forms the pelvic brim over here. Okay. So to that pelvic brim is the end of the descending colon over here. Okay. So this descending colon will be situated a bit posteriorly and above when compared to the ascending colon. This you are supposed to remember. What is it? So the descending colon will be situated a bit deeper and above to that of the, when you compare with that of the ascending colon over here. Getting it out? Right? Because the liver is pushing it downwards over here, it will be a bit in front over here. But there is no liver and everything over here, it will be going a bit backwards and upwards over here. Getting out? In anatomical position also, you have to keep it in this manner. I have already told you. Is it or not? Right? So what are the relations? Posterior relations will be the same thing. So here it will be related with the what's the difference? Psoas major especially, and then what are the nerves which are coming out over here? The same nerves which are related over here will be related over here, along with the gonadal vessels over here. Getting it on? So this is about the descending colon. So within this concavity will be the situation of the jejunum above and ilium below over here. Getting it on? Jejunum above and ilium below. Of course, the entire it will be operated with jejunum above and ilium below. But mostly the jejunum will be situated towards the left side and ilium will be situated more towards the right side. This you are supposed to remember. Okay. Right. So from the pelvic brim onwards, the sigmoid colon will start. So it will be in the form of an S shape over here. Okay. So this is the first part, is the vertical part of the sigmoid colon. Second part is the horizontal part of the sigmoid colon. Third part is the oblique part of the sigmoid colon, just like the ureters over here. Ureters, could you able to remember? The pelvic part of the ureter, what are the three parts? Vertical part, oblique part and intravesicular, intramural part over here. Just like the same manner, this is all the way from left to pelvic brim, downwards over the lateral pelvic wall will be the vertical part of the sigmoid colon, and then followed by horizontal part. So this will be going horizontally over here. So this is the second part, which is the horizontal part. Okay. Above this will be, the structures will be lying over here. Above this horizontal part, the structures will be lying. What is it? Here. Above the sigmoid colon, above the second part of the sigmoid colon, the structures will be lying over here. Coils of small intestine, what is that? Ilium. Ilium will be there over here. Below this transverse part of the sigmoid colon, there will be either uterus or urinary bladder. Could you understand now where it is situated? This is situated towards the lateral pelvic wall, but the second part is the horizontal part, which is situated in between the intestines above, small intestines above, and the urinary bladder in case of males, or uterus in case of females. Below. Getting it on? So here will be the either urinary bladder over here or the uterus over here in between the intestines and the urinary bladder is the second part of the sigmoid colon over here. So this is now the horizontal body situated at the level of the lateral pelvic wall on the left side. That will be reaching towards the right pelvic wall over here. and then turns obliquely downwards and will be continuous with the rectum over here at the level of third sacral vertebra. What is it? Third part is related to the third sacral vertebra. That means the third part will be ending at the level of the third sacral vertebra in the middle and continues downwards as rectum and further continues downwards as anal canal. Okay. So this you are supposed to know over here. Okay. So the transverse colon will be hanged by means of the transverse PC colon. The same manner sigmoid colon will be hanged by means of sigmoid mesocolon. Sigmoid mesocolon, which will be like an inverted V shape all the way arising from the posterior abdominal wall over here. So this will be hanging the sigmoid colon in this manner. So what structures will be passing through this sigmoid mesocolon? Sigmoid mesocolon. And one more thing, sigmoid mesocolon will be having two limbs. What is it? What is this? One is the left-sided limb over here. One is the right-sided limb over here. This left-sided limb will be going over the pelvic brim over here. Could you understand? These are the two limbs. One is the left limb and one is the right limb over here. The left limb will be going over the pelvic brim. Okay, this is the pelvic brim. I have told you already. Over the pelvic brim, this left fold will go. Left limb will go. The right limb will be going over the sacrum over here towards the third sacral vertebra, where it is converting into the rectum over here. Getting it out? So here will be the pelvic brim. Here will be the sacrum over here. Okay, because sigmoid colon is situated a bit towards the left side. So all the way pelvic brim and towards the sacrum over here. Okay. So this will be carrying which vessels and nerves over here? Sigmoid arteries, which are the branches of inferior mesenteric artery. What are the three branches of the three sigmoid branches? Highest, distal, lowest or least. Anything. The lowest or least will be anastomosis with an artery. What is that artery? Not superior rectal artery, yeah? Not superior rectal artery, yeah?
Left pubic artery.
Inferior rectal artery only. So if the anastomosis is absent, that area is termed as Sudeck, right? Point of Sudeck over there. Okay. Okay. If the anastomosis is absent over there. Okay. So it has not got that much importance, but this terminology is important. What is the point of Sudeck? It will be asked in the examination. Okay. So what the blood supply of the entire colon and sigmoid colon? Sigmoid colon we have discussed just now. And the ascending and transverse and descending colons, what's the blood supply over here? Superior mesenteric artery will be supplying the cecum, appendix and ascending colon, and transverse colon up to junction between right third and left one third. So this will be supplied by superior mesenteric artery. What are the branches which are supplying the ascending colon and transverse colon over here?
Middle pubic artery, right pubic artery, middle pubic artery,
Right colic artery and middle colic artery. Both will be anastomosis. And also, of course, one more artery over here, iliocolic artery. Okay, then followed by. So the left one third part and descending colon will be supplied by what is it? Left colic artery, which is a branch of inferior mesenteric artery. Okay, right. Veins, how they will drain? From this part it will be draining into superior mesenteric vein, that will be ultimately draining into portal, joining with splenic vein. Then what about this part? Sigmoid veins and inferior mesenteric vein. Inferior mesenteric vein ultimately drains into splenic vein. So that ultimately drains into portal vein over here. So this is the portal system of veins which are draining it into. Getting it out? So for example, if there is a malignancy of the sigmoid colon over here, malignancies are common in sigmoid colon compared to the other colons over here. Okay. So malignancies is common in sigmoid colon. Okay. So this malignancy will be reaching to which organ, especially compared to the other organs? Liver, obviously, because the veins will be carrying the metastasis all the way from this part into the superior mesenteric vein, from superior mesenteric vein into splenic vein, from splenic vein into the portal vein, from the portal vein into the liver. So the metastasis of the large intestine, nothing but sigmoid colon, will be reaching the liver eventually. Getting it on it? So what are the other things over here? There is a terminology called the diverticulosis of the ascending colon. What is that? Diverticulosis. Diverticulosis is common in Which part of the duodenum? Diverticulosis is common in which part of the duodenum? Second part of the duodenum. What is the complication of the diverticulosis in case of duodenum? What is the complication of the diverticulosis in case of duodenum? What will happen? Yeah, peritonitis, how it will happen?
So
You're absolutely right. Exactly. The diverticulum gets filled with the food material and it bursts open to some extent. So that will be leaking the things into the peritoneum. That leads to the peritonitis, generalized peritonitis. Okay. What is the difference between localized and generalized peritonitis? Entire peritoneal cavity is occupied by the infection or the inflammation. That is nothing but the generalized peritonitis. Localized peritonitis, you already know. Local area, particular area. Okay, confined area. Okay. So the same diverticulosis will be occurring at the ascending colon, common in ascending colon over here. So if this diverticulosis converts into diverticulitis, what is meant by itis? Itis means inflammation. Pancreatitis, colitis or gastritis. Itis means inflammation. So if there is any infection to these diverticulosis means nothing but the mucous membrane which is present over here, piercing the muscular wall over here and will be protruding outside the wall over here. That is called the diverticulosis. Getting it out? So more form from perforation up to some extent. Okay. But whenever this is intact over here, but there is an inflammation of the diverticulosis, what will happen?
Intestinal.
No.
The small intestine will get
No. How it can be obstructed? This is outside the intestinal wall and this got inflamed over here. So the lumen is intact. There might be painful passage of the, that is wherever the fecal matter is passing, there might be pain, but there is no obstruction over there. Then what might happen? Alright? No. For example, so here you can find the small intestines over here or not? Here you can find the small intestines. Small intestines will be located over here. Small intestines are located over here, right? So inflammation can irritate the wall of the small intestine over here. Is it not? Whenever the inflammation is occurring over here, the same inflammation can spread to the other areas over here. Okay. Whenever the inflammation is giving the inflammation over here, small intestine also, there occurs a tract between the two intestines over, nothing but the large intestine and the small intestine over here. Could you understand? What is it?
The joint.
Yeah, absolutely. For example, there is a small intestine running over here in this man. Okay. So there is an inflammation of this diverticulum over here. So that is infecting and inflaming the small intestine's wall over here. So after some time, what will happen? There will be perforation because of the inflammation over here. So because of the inflammation, there is fibrosis over here. So this wall and this wall will be fused with each other, but the opening will be maintained over here. Get it or not? So whenever there is an opening over here and there is a communication between the large intestine and small intestine, what will happen over here? Fistula. What is fistula means?
Abnormal connection between two.
Fistula is an abnormal communication between the two hollow viscus over here. Get it or not? So either it will occur with the small intestine or with the ureters or with any other structure over here. Get it or not? So if there is a communication between these two, what might happen? The fecal matter which has entered over here will enter back into the small intestine over here. Getting it over? Irritating the small intestine and that leads to inflammation, that leads to perforation again. Getting it over, right? So this is the complication of the diverticulosis over here, following the diverticulitis over here. Getting it over, right? There is one more thing called volvulus. What is a volvulus means? Volvulus means what? Obstruction occurs as a complication of the volvulus. How it will occur? So okay, you are saying about after obstruction the distension occurs. Okay, I'll tell you what is volvulus means. Volvulus means, for example, take the sigmoid colon over here. If the sigmoid colon is much more enlarged in certain patients, rather than 40 centimeters, if it is about 90 centimeters, for example. Okay. So what is happening over here? The length of the sigmoid mesocolon is smaller compared to the sigmoid colon over here. The sigmoid colon's length is smaller over here, about some 10 to 15 centimeters, for example. Okay. It is holding this 40 centimeter sigmoid colon over here normally in all the individuals. But in certain individuals, they will be expanding. or elongated sigmoid colon over here. Initially it is 40 centimeters, now it is 90 centimeters for example. Okay, it has enlarged double over here. So what will happen? Because it is shorter and the intestine is longer, there will be, what is it?
Torsion.
Coiling among, torsion among the coils of sigmoid colon itself. Getting around, for example, this is a sigmoid colon that will rotate around itself over the sigmoid colon. Could you even understand or not? Could you even understand or not? For example, if you are carrying through a carry bag a small amount over here, a small amount of something over here. But if the carry bag is elongated, whenever you are carrying, it may rotate on itself or not. So in the same manner, this smaller carry bag over here can't able to carry the elongated sigmoid colon. The sigmoid colon will rotate around the sigmoid mesocolon over here. So this rotation will occur generally anti-clockwise manner. Getting it on? So whenever there is a coiling around itself, what will happen? There will be obstruction of the sigmoid colon over here. That leads to strangulation. That leads to ischemia. That leads to necrosis. That leads to perforation again. Getting it on, everybody? Okay. Volvulus I have discussed over here already. In case of cecum, could you remember or not? No? No? Yes, sir? Okay. So what is volvulus? Volvulus means the enlarged intestine will be rotating, nothing but the sigmoid colon will be rotating around this axis, nothing but the sigmoid mesocolon. So that coiling will be obstructing the sigmoid colon by itself. That leads to strangulation of the blood vessels over here. That leads to ischemia, necrosis of the sigmoid colon over here. Okay. So whenever the strangulation occurs over here, what will happen? There will be obstruction to the large intestine at the level of the junction between the descending colon and the sigmoid colon over here. Could you understand? So the large intestine obstruction occurs because of the volvulus at the sigmoid colon. So this part of the intestine will be distended over here because of the obstruction over here. Getting it or not? Right? Could you able to understand or not? Okay. Why I am saying this again and again? Because these will be asked in the examinations over here. Okay. And what is intussusception? I have already discussed during iliocecal junction. What is intussusception? Intussusception can occur in Okay, what will happen? So in case of ileum, intussusception means telescoping of one intestine into another. Getting it or not? For example, the normal intestine is over here in this manner. So if one of the intestine is telescoping into or entering into the other intestine, this area is termed as the intussusception. What is this spelling? Intussusception. What is it? Intussusception over here. Intussusception means telescoping of one intestine into another intestine. For example, over here, there will be large amount of Peyer's patches will be present over the distal 10 centimeters of the ileum over here. That will be forming in case of children, almost like a semi-solid mass because of the viral infections over here. Getting it over? That leads to entry of the ileum into the cecum, nothing but the intussusception. What is the result of the intussusception? Intestinal obstruction, obviously, right? Because ileum is entering over here and occupying the entire cecum, so there will be intestinal obstruction. These intestinal obstructions occurs whenever there is intersection between ileum and cecum over here, or ileum and ileum over here, or colon and colon over here. Getting it or not? The colon can be intussuscepted into another part of the colon over here. Getting it or not? Or sigmoid colon can be intussuscepted into descending colon over here. Any intussusception can occur that leads to intestinal obstruction over here. Getting it or not? And one more disease card you are supposed to remember. What is the Sishman's disease like? Failure of mobilization. What is the Hirschsprung's disease like?
The myopathy and the substance.
So one area of the intestine will not be mobile over here. There will not be any peristalsis occurs at this segment of the intestine over here. Why? Because
Absence of the
absence of
impact of the liver questions during
Fishburne's disease is also termed as a congenital megacolon. Why? Because congenitally there will be absence of the nerve cells over here. Myelin and meniscus plexus will be absent in case of congenital megacolon or Fishburne's disease. So in this part of the intestine, there is no any nerve cells over here. There will not be any peristalsis occurs over here. Peristalsis means contraction, dilatation will not occur over here. So if there is no contraction and dilatation occurs over here, what will happen again? Again obstruction, because this is not moving over here. Whatever the fecal matter enters over here will not be protruded further. So it will be obstructed at this level. Okay, because there is no contraction to push the fecal matter downwards over here. So here will be the obstruction. So the entire colon till the cecum will be distended over here. Okay. Why can't the fecal matter enters? Why can't the fecal matter enters from cecum into the ileum over here? Why only till the cecum?
Due to the presence of valve.
Exactly. So the valve between the ileum and cecum will be preventing the entry of the fecal matter all the way from the cecum into the ileum over here. Very good. Okay. And what is the nerve supply? What is the nerve supply?
Sir,
Fishburne's disease. Future means obviously.
Because in our request told sometimes due to constipation, the stool does not pass out of this problem. In this case, there is no such problem in the.
That's what obstruction is there. Obstruction will lead to distension of the large intestine. If the obstruction is not clear, that leads to perforation. Obviously. So the fecal matter will be spilled into the peritoneal cavity over here after certain distension over here. Okay. Always the intestinal obstruction must be clear. Very well.
We can cut that part and join
Definitely, you
them.
can cut this part and then expose these two. That's all. Okay. So with this part, the sympathetic nervous system will be supplied by T12 and L1 segments of the spinal cord in this part. In this part, what is this part? Junction between the right T3 and F1 and the transverse colon. This entire part will be supplied by this sympathetic nerves all the way from T12 and L1, and rest of the area will be supplied by. Rest of the area will be supplied by. Rest of the area will be supplied by. What? We have discussed now yesterday, day before yesterday. The pelvic viscera which is situated over here will be supplied by the same sympathetic nervous system. And what about the parasympathetic nervous system? S2, S3, and S4 in the same manner. Got it? The rest of the area is supplied by below L1, right? Obviously L2, L3 over here. Getting noted? L2, L3 will be supplied in the rest of the area of the colon over here. Descending colon and the sigmoid colon over here. Sympathetic nerve. Sympathetic nerve, what it does over here? Sympathetic nerves will be supplying the walls of the intestine for relaxation of the musculature over here. But parasympathetic nervous system will be contracting or constricting the musculature over here. Contracting the muscle, not constricting. Contract. What is the difference between constriction and contraction? Constriction is narrowing over here. Contraction means the size of the muscle will be reduced. Contraction, muscular contraction. Okay, that leads to constriction of the lumen of the intestine. That is both are different entities. Okay, right. And parasympathetic is from S2, S3, and S4. Okay, what is the parasympathetic? What is different based on the function, based on arrangement of the sympathetic and parasympathetic nervous systems. The spinal segments, foregut and midgut and hindgut over here. So that's the difference. Getting it now? Midgut and hindgut over here. Okay. So from here is the S2, S3 and S4 over here. But what about this part will be supplied by parasympathetic nervous system. S2, S3 and S4, all the way from this to the distal aspect over here. And who will supply this part? Parasympathetic nervous system will be supplied by? No. We have discussed earlier. The junction between the right two-third and left one-third, the midgut and hindgut will be differentiated by these parasympathetic nervous system. From here onwards, S2, S3 and S4 over here. But before that, which parasympathetic nervous system will be supplying? Vagus. Vagus nerves will be extending all the way from Vagus nerve will be supplying all the way from
10th grade.
Vagus nerve is supplying which structures of the four-gutted midgut, right? Esophagus, all the way from esophagus, stomach, duodenum, jejunum, ileum, cecum, colon, and the junction, or in between the right to the left one. Till this junction will be supplied by the vagus nerve. Remember this properly. The parasympathetic nervous system will be supplied by S2, S3, and S4 of this hindgut over here. The foregut and midgut are supplied by the vagus nerves. As simple as that. Would you understand? Vagus nerves will be arising from brainstem. Which area of brainstem? Now what is it? From midbrain, pons and medulla. Among these three, from which area it will be? Okay, not even physiology also. Not at all. So, from middle oblongata, the vagus nerve will be arising. Okay, so it is that way. So if there is a diverticulitis, of the sigmoid colon over this horizontal part, what might happen? Which fistula might happen over here? Yeah, fecal fistula, but which, in between which and which structures the fistula will be happening over here? What? Urinary bladder and the sigmoid colon over here. So what will happen? So how the patient will present with? What? Absolutely. The fecal matter will be entering into the urinary bladder, and through the urethra, the fecal matter will come out. Getting it or not? So there is a fistula which will be occurring in between the sigmoid colon and the urinary bladder. So fecal matter will be entering into the urinary bladder over here, because sigmoid colon, the main function is to store the fecal matter for some time. Okay. So the fecal matter will be passing through the urethra over here. Getting it or not? Right? So that is a complication of the diverticulitis at the level of the sigmoid colon over here. Understood or not, everybody? Right? So in between the tinea coli over here, there is a presence of longitudinal muscle organ. Yes, Sabaka? Between the two tinea coli. So one more cardinal feature of the large intestine is epididymis epicloica. What is epididymis epicloica? Fat-filled structures, peritoneal lined fat-filled structures are called the what is it? Appendices epicloica. Okay, these are fat-filled pouches over here, which are situated between tinea libera and tinea mesocollica. These are mainly situated in between tinea libera and tinea mesocollica. This is one very important point. So, what is the use of these appendices epicloica? Absorption of fat. Why absorption of fat? Fat will be absorbed through lacteal. Obviously, lacteal. Fat will be absorbed through lacteals. Where are lacteals present? Villi. Villi contains the lacteal. That will be carrying down all the nutrients and the fat. Okay. So these appendices epicloica are situated within only the colon, not in the rectum or in the appendix over here. Okay, could you understand? Not in the cecum and appendix, not in the rectum, the appendices epicloica are present over here. But appendices epicloica are present only in the colons, ascending colon, transverse colon, descending colon, and sigmoid colon. Got it or not, everybody? These things are the viva questions which should be asked. In between which and which tinea coli the appendices epicloica are situated over here. Got it or not? Understood or not, everybody? Right? Did you start studying now? Right? You start studying or not? Right?
So what is the constant?